Now, this is a panel session. I'm hoping it's going to be a panel and audience participation session because it's about a topic that actually should be at the centre of all of our thoughts right now. So please prepare to speak up because we really want it to be interactive. Apologies to those of you who've been through this exercise before, but it's always really useful for the people up here to know something about the people out there. So could you put your hand up, please, if you are a regulator? If you are a user of a service, a carer, or a family member of a user of a service, welcome back. Doubled in number. That's good. If you are a provider of home care. Okay, that's less than half this time. And if you are a commissioner. Many more commissioners. Great, you're very welcome. Excellent. So we've got a really mixed group, mostly providers and commissioners. And that's handy because we have here people representing providers, Roger Booker, and commissioners, Mike. And we're going to kick off with a start from Lauren, who's done some very useful research for LGiU on commissioning for outcomes. And my question at the end is going to be, what is an outcome? Lauren.
Great. Can everyone hear me? Yeah? I'm taking that as a yes. So the question posed by this session is outcome-based commissioning, myth or reality? Which it sounds like a fairly simple question, but I think that's deceptive. I think it's actually very complex. What I'm going to do today is talk about a piece of research that the Local Government Information Unit published last year, which focused on outcome-based commissioning, specifically in a domiciliary care context. And I'm going to talk a bit about the lessons we've taken from that. I think that the danger is that outcome-based commissioning has become almost a bit of a motherhood and apple pie type of statement without much actual consideration of what we mean by it and what it means in practice. And for me, the crucial thing in this area is to get a kind of shared understanding of what we mean by outcomes. And only then can we decide as commissioners, is that something we actually want to use? I'll come back to this later, but I'll start by talking a bit about our research project. We initiated this piece of work in spring 2012 because we're a membership organisation and we were getting a lot of feedback from local authorities that this was something they were very interested in. But also because we were getting a bit of a discrepancy in what we were hearing about outcome-based commissioning. When we spoke to local authorities, they all said, yeah, sure, outcomes, that's our shtick. We do outcome-based commissioning, that's what we're here for. But when we spoke to providers, they said, well, no one's ever commissioned me on the basis of outcomes. We wanted to get to the bottom of this misunderstanding, so we undertook a long piece of research which was kindly funded by social care provider Mears. We spoke to a lot of providers and commissioners, and based on that we ran a survey of commissioners, ADSs, lead members for social care. We had a really good response rate with about 210 responses from 113 upper tier authorities. And we then followed this up with some more in-depth interviews of about 20 councils to find out what was going on the ground. And based on this, we published a report in October 2012. I thought it'd be useful just to share some of those survey findings with you today, because I think it helps hopefully prompt a discussion and maybe respond to that initial question about myth or reality. One of the first things to come out of the survey was that respondents recognised there were major challenges for the way social care is provided. 3/4 disagreed with the statement, our current systems and processes will be sufficient to manage social care provision in future, which I think reflects some of the financing challenges that we're facing at the moment, but also probably a bit of uncertainty about what commissioning should look like in future, in the current changing policy environment. Outcome-based commissioning was seen as a huge priority. More than 70% saw commissioning for outcomes as a very important priority for their local authority. But 3/4 of respondents also said they regarded a culture of running services on a time task basis as a really big barrier to improving commissioning in future. There was clearly some confusion about what actually defines outcome-based commissioning. Over 60% of respondents to our survey said that they already commissioned on the basis of outcomes in most or all cases in adult social care. But at the same time, over 95% said that they still pay domiciliary care providers according to the time they spend with the user. That's the sort of, the 15-minute, the minute slot, that rather than against the outcomes. And I think that's really important, and that's really the crux of this issue about definition that I'm talking about. Because while we're paying providers for the amount of time they spend with a service user, we're not paying them on the basis of outcomes. Commissioning, by the hour or the minute tells us how long a provider spends with a user, but it doesn't tell us anything about the quality of that service or what it's accomplished for that individual. We may have identified outcomes in the care plan, and I think that's something we're getting better at, but this alone doesn't make it outcome-based commissioning, because then those outcomes are being translated back into time, into a slot of time. And in some instances, that's probably for good reason. But I think it's important to be clear about what we're doing and why. I think there is a structural problem at the heart of time-task commissioning in domiciliary care, and it's something that a lot of councils recognise. In the interviews that we conducted with local authorities, people had a kind of broad consensus around two principles. One was about the importance of independent living services, so services that don't generate unnecessary need in the system and that help people to live as independently as possible for as long as they can. And the other is about the core value of care workers and the importance of investing in them. And I think, I'm going to stop in a minute, but I think that when we commission on a time-task basis, we aren't necessarily responding to those two core principles that people highlighted. So I'm going to sort of stop there because I know we want to have a chance to talk about this, and Mike and Roger will have a view. But in response to the question framed by this discussion, I don't think outcome-based commissioning is a myth. I think there are examples of it, particularly in reablement contracts. Wiltshire Council has developed some really interesting work with their Help to Live at Home scheme. And I think actually some supporting people contracts display some outcome-based commissioning examples as well. But I do think we have a problem with definition and what we mean by it. And I also think that commissioning for outcomes is quite challenging and isn't a quick fix solution to the problems that we're facing as a sector. Having said that, I think the current time-task model of commissioning that we use for home care does have some serious sort of economic flaws in it as a model, and we can talk about that perhaps in a minute. And that we can't really meet some of the kind of structural issues around cost, quality, and personalisation until we start to address some of those challenges. So that's my bit. Discuss.
Thank you, Lauren. Are there any sort of very quick factual questions to Lauren? Because otherwise everything else can go into the open discussion. No? Okay, thank you. Lauren, if you'd like to come and sit down. Now I'd like to introduce Mike Webster, Assistant Director at North Yorkshire County Council, and previously of Lancashire, and that becomes relevant because I know that Lancashire had taken outcome commissioning quite a long way. Mike, do you want to just give a very quick response to that?
Okay, thanks, Bridget. I'm going to speak both as a commissioner and personally with my personal views as well. I think that was an excellent introduction from Lauren. My short answer to myth or reality is that for the bulk of local authority commissioning, outcome-based is a myth. We don't do it, we struggle to do it, and Lauren, I think, almost described what I would call the hamster wheel we're in that stops us doing it. I'd also add to that another factor that we're finding in North Yorkshire at the moment. Our charging policy actually means some service users don't want to get involved because they want to know exactly what time they're receiving and how much they're going to be charged for it. So that's the problem. The question I would be interested in when we get into the open discussion is anybody in the room that has successful examples of how it's done and whether you're doing it. I think that would be really useful to share. But just to conclude what I want to say, as was alluded to, when I was over in Lancashire, we did do a bit of work around outcome-based contracting. And the lessons I think I took away from that, first of all, if you get 6 people in a room and ask them what outcome-based or even what an outcome is, you probably get 7 different answers. So there's an issue there. But I think what came out of the work we did was, what is key to it for me is actually the level of trust that can be built up between the commissioners, the providers, and almost the commissioners handing the trust to the provider, and then the provider earning that trust by the relationship that's built up with the people receiving the service. And when I roll personalisation and outcome-based contracting together, what's vital for me is how that starts. The local authority should have an idea of what it wants from a domiciliary service and what it wants in partnership with that individual. But the key element is the provider then sitting down with the individual and asking the very basic question, how are we going to support you? And the local authority butting out and allowing that to happen. And then on a high level, monitoring, making sure the service is up to quality, etc., and checking out with the service user they're happy. But it's only if you get that relationship in place will, I think, we'll ever get away from, did you turn up at 9 o'clock? Did you leave at 14 minutes past 9, 16 minutes past 9? And that sours the relationship for me currently.
Thank you, Mike. Very thought-provoking too. And now I'd like to introduce Roger Booker, who's the Chief Executive of Sevacare, one of the larger home care providers, and a very active member of the United Kingdom Home Care Association. So, Roger, over to you.
Thanks, Bridget. I think both Lauren and Mike have put it very succinctly and very accurately. The connection with the service that Mike refers to is that I was that provider that delivered what we considered was an outcome-based, personalised service within Lancashire. The sad thing is that was 7 years ago, or 6 or 7 anyway. And here we are today having exactly the same debate that we were having at that time. And Mike is right in that the key to the success of the service, and whilst we ran it, it was very successful, is the relationship and the trust between the commissioners and the provider. And we all know in domiciliary care it's a very difficult service to deliver totally correctly all of the time. You're reliant on too many people for too long and too many visits, and all sorts of things can go wrong in between that. I think, however, the intention is that if the provider is geared up and committed to doing it correctly, then it will work, and the things that maybe don't work brilliantly will just be things along the way. That needs the provider to be trusted by the local authority, and unfortunately history has shown that the methodology of commissioning is baked in as a time and task based, because predominantly the commissioners aren't prepared to trust, or they aren't prepared to release that control, and they feel that if they do, perhaps the money will run away with things, things won't work. What we did was we said, right, okay, here's the basis of the service, here's the cost of the service, and it might be 10 hours a week, and the price might be £12.50 an hour. What we said was, right, okay, well, that represents £125 a week worth of service. Turn it over to the provider and say, go ahead and deliver £125 worth of service that week for the people, for that person. And we were able to do it, and time disappeared, yet we were constantly talking to the users and saying, what would you like to do? Clearly there were certain key tasks to enable to support people at home, which we did, but people then started to talk beyond that. They started to talk about their psychological well-being, social interaction, and we were able to put service users together to have some contact and all sorts of different things, and it did work very well. And it's sad to me that here we are today and it isn't happening, and there aren't really any barriers to it. We just need the commissioners to say, yeah, we will let it go, and we believe you are providers who we can trust to do it, and let's then observe and measure and monitor what's going on. 6 weeks later, 12 weeks later, 3 months later, we can see if it's working or not, and there's no reason to not to do it, in my view. The final point I'll make is, of course, in the world in which we have got an ageing population with a finite number of people who are prepared to do this work, if we continue to commission on time, then that time will increase. And therefore, there's nothing baked into the system to reduce the amount of time, potentially, that might be there to enable people still to be independent at home, but make the money go further. And at the moment, it can't go further because you say, OK, we've got another older person here. That person needs another 7 hours a week. It's just not going to work. So we haven't got any choice but to go there. Sadly, it's taken us too long so far.
Thank you, Roger. Well, some very thought-provoking introductory comments there. It's now over to you. Let's have an open debate around this. Can I say, I don't want to put anybody on the spot, but it would be particularly good to hear from anybody who is a carer or a customer, because they are not represented on the platform at the moment. But and the other thing is we're going to be playing microphone tag, because we have one roving mic. We have a question. Can I take the question in the middle first, and then I'll come back to you? Can you tell us who you are and where you're from, please?
Hi, my name's Patrick Hall. I'm from the London Borough of Newham, and I'm a commissioner in adult social care. Some really good points up there. I think isn't the problem that we're mislabeling it as outcomes-based commissioning? More that what we need to move towards is commissioning outcomes-based services. I think this is sort of the confusing thing. Even the most forward-thinking of councils like Wiltshire are actually still allocating resources on the basis of a number of hours that would be required to produce an outcome. You know, so I do think we're really mislabeling the way that commissioning works, you know, and we really need to think about the way that we allocate resources at the beginning of this process. And it's not just a question of changing the one part of the way that we purchase services. You know, that's not going to deliver the transformational change that we need. I think what we're really talking about here is breaking down the oppositional relationship between commissioner and provider, and to build trust and say to providers that commissioners themselves, particularly in a time like now where there's so much organisational change, there's so much change of personnel, change of expertise, we aren't experts in everything. And it's about time that we started giving a bit of trust to people that have been providing services for a long time, and actually changing our relationship with the people that use services and trusting them to say, actually, you know, it's you that knows best how these services should be delivered, you know, and really changing that relationship to design our product around what our customer wants. Whereas what we've been doing is designing a process which suits us and feeds the beast, and that's what we need to change. And believe me, we're just as much guilty of doing that as anywhere, but I think that's the main issue here.
Mirrors. Does my mic work? Yeah, it is now. Thanks for that. I mean, I think that mirrors my views. And just as Roger was talking about the work we did a few years ago, one of the key issues in there was, yes, we could talk about outcomes, but you almost had to put a currency or value on that. And we did end up with hours that were converted into money that actually said, that's the resource. Talk to the service user about how you use it. And some of the really key issues that I recall from that was, for example, a lady who the support was to get her out of bed every morning, get her up, give her breakfast and get on with the day. Because she knew she had some control over that, she started to have her feet over the bed in the morning when somebody arrived. And the aim was she wanted to save up enough time and resource to visit her husband's grave that she'd never done. And that was the ended outcome of that. But it was all about the local authority stepping back and giving control to the person and the provider, and not having to come back to our bureaucracy and say, can we do this? Or worse still, we only need half an hour in the morning now because she's ready. One of the ways I think, in my head, we can do it going forward is clearly the use of individual service funds, where even if someone doesn't feel they want to manage a direct payment, they can actually manage their budget with the provider. And I think that's one of the ways going forward. Just a final point, though, and I say this as a trained social worker, even though I'm in the echelons of commissioning now, our staff have to go under a huge culture change, because we want half the time to micromanage these things. And to be honest, we don't do it very well. So that's got to change.
There are a number of other people wanting to come in, so thank you. There's a number of other people wanting to come in, so I think we'll move on and we can just open up the discussion. Gentleman here and then a lady there.
My name is David Hogarth. I'm from the Westminster Health Watch, but I'm also a coordinator of a small charity providing befriending for older people in a part of London. And I'm in a bit of a quandary, because I want people to go and be able to visit the graves of their husband if they possibly can. And in the old system, that was absolutely out. It didn't happen. On the other hand, I mean, I've seen so much rubbishy care in London. I've talked to so many people that I've seen with rubbishy care. Short on compassion, short on the actual work done, bad timing, people leaving early, not because they had to get to the next place, but because they wanted to be paid 1 hour to get 1 hour's pay for 20 minutes work. I do not trust providers, and I do not want commissioners. I fear commissioners trusting providers, and I'm sorry to say that to those who are providers here, but I hope the commissioners who are here will listen. So, in a way, what I would like to see is throw out the task, if you like, but keep the time and have the outcomes. Because I don't agree with you that time is not about quality. Electronic monitoring not only shows you when people come and when people go, which is an aspect of quality, but also it shows you continuity, because people care about having the same carer, not having hundreds and hundreds of changes. And it also shows if calls are missed. All of those things are aspects of quality. I would like to see time kept, but I would like to see it blended with outcomes so that people can go and visit their husband's grave.
Thank you. Yeah, I think that's a very good point. I think the point really that you're making is about the quality of providers. You know, you get what you commission for, and you know, if we do become wrapped up in the minutiae of measuring the sort of the minute by minute time which people go in and out of properties, then we do lose track of the quality and that relationship with providers that Mike was describing earlier, and I think that's where you start to, you know, have poor performance. If we could move to a position where we have a better relationship with the providers that we have, which is very difficult because I think we've created models where you have hundreds and hundreds of providers on a framework contract and no real, you know, the direct relationship is being lost partly there, then it gives you that space to actually trust providers to have that relationship and to work with the service user to try and develop a care plan that meets their needs and achieve the outcomes that they want to. If you can trust providers to be in the right place at the right time, and you know you can do that, then that frees you up to think about the longer term aims of the service. I think the other problem is if you get when you are focusing very much on the time and task, first, you are kind of almost giving providers an incentive for that care plan to increase over time because they're being paid on the basis of time. That's all that they're being told to focus on. And the only thing that as a commissioner you can make savings on is by reducing the hourly rate, which over time then affects the frontline quality of service. It's a kind of zero-sum game. So anyway.
I'd just like to comment and say that I fundamentally disagree with the gentleman. Everyone's entitled to their opinion. You either look at the time that you're going to spend with somebody and the task that you're going to do, or you commission a service which says this is what this person needs. And you use time in order to value the amount of money that you will pay for that service, but then you say, right, this is what that person needs, and that person's needs may change over time, and some things might be specifically important to that person tomorrow, next week, which are entirely different than what they might be important to in 2 weeks' time. I do agree that the service provision generally by domiciliary care providers is not great. I think fundamentally one of the key reasons for that is because it is commissioned in a way which almost causes that to be the case. I can only speak from our point of view, and Mike will support me on this. When we did it, it transformed the service. It completely transformed the experience of the older people who were receiving the service, and it completely transformed the attitude of the staff who were delivering it. And what we were able to do is to say, we know that we are going to be paid this amount in total for this service. We can deploy a number of staff, which meant that was the right appropriate cost to be delivered for that service, and they were working on a flexible, committed basis across all of the service users in those areas, and they were popping in, popping back, going in, talking. There was never a problem. Nobody was late because late didn't exist, because the time wasn't specified. Nobody had a complaint about anything to do with time because it wasn't there. You can measure time just to make sure people are turning up. You use CM2000 or whatever other system you've got. Do it, fine. Use it as a quality tool. Don't use it as a methodology of saying, right, this is a good or not a good service. It goes out the window. So.
Thank you, Roger. Ladies and gentlemen, we are out of time, but I did promise the lady here that she could ask her question. Okay, thank you. I'm really sorry. I think what we've learnt from this is a message back to the organisers. A 30-second response. All right, go for it.
Just to pick up on that question, what I do think commissioners have a responsibility is to monitor providers, and unacceptable provision has to be looked at and acted upon. So I take that point. What I don't think is providers should meddle in every microsecond of a provider. If we're convinced a provider is good and our monitoring says they're good, we trust them. We don't accept bad practice.
And there can't be anything wrong with building trust. We know what happens when there isn't trust. Thank you very much, everybody. I'm really sorry I'm having to close this session now. Maybe next year we'll be allowed a little longer for the session. There can be about a 2 to 5 minute break now while we just switch over the mics. But can we please thank our panel for their presentations?